My name is Micah Mazurek. I'm a clinical psychologist, and I'm going to be talking with you today about co-occurring mental health issues in people on the spectrum. So I'd like to get a sense of who's in the audience, if you don't mind. Who in the audience would identify as a self-advocate or someone on the spectrum? Great, awesome. Family members? Great. Any service providers, clinicians? Teachers. Who else am I leaving out? Other research people? Researchers? Great. Awesome. So we've got great representation across a lot of different groups. So I'm going to be focusing kind of a broad brush across different kinds of mental health issues and challenges that are common in people with autism. And we're going to do a lifespan approach. So this is pretty much of a bird's eye view. Since we only have a short amount of time, we're not going to get into a lot of depth in these areas, but I'm happy to answer questions afterwards and follow up with you on any things that come up during our discussion today. So I've been really interested in understanding co-occurring conditions in people with autism because I think sometimes these issues can cause a lot more difficulty for people than what we might think of as the diagnostic features of ASD. I'm having a little trouble with this. So when we think about autism, in terms of the DSM-5, there are two main categories that we really pay a lot of attention to. And those are social challenges and differences in behavior. So what we might think of as repetitive behavior or very strong interests. So these are the classic kind of diagnostic features. But most of us know that it's actually the co-occurring challenges that can lead to more functional difficulties and distress for people on the spectrum and for their families. And what we know is that in children on the spectrum, the most recent evidence tells us that 95% of the population of kids on the spectrum have a significant co-occurring condition. So that's pretty much the whole population. So I think this is something that we really need to be thinking about as self-advocates, family members, and folks who are in any way working with kids or adults on the spectrum. So there are what we think of as sort of neuropsychological or cognitive differences that are really common if you're on the spectrum. Those include, for some part of the population, intellectual difficulties, but for most of the autism population, we also see executive function problems, and we'll talk about that in a little bit more detail in a minute. There's also a lot of co-occurring medical conditions that occur at a much higher rate in the autism population than in the general population. Dr. Ellen Davis is going to be doing a whole workshop on that later today, so if you're interested in that, that's the place to learn about these conditions. Today we're going to talk about the most common mental health conditions. And those include anxiety, depression, ADHD, and then for subpopulation, difficulties with challenging behaviors addressed towards themselves or someone else, so aggression or self-injury. So because we're talking about mental health, if we take a look at the whole population of people with autism and focusing specifically on kids, 1 out of every 10 children with autism, 8 of them are going to have a significant mental health issue. So that's the majority of the population, which I think really highlights how important this is when we think about improving quality of life and helping people live happier lives. So when we look at kids, there's been a lot of studies looking at prevalence of these issues, and the rates vary depending on how you did your study. But in general, ADHD is very common, affecting about 60% of kids with autism. Anxiety is also very, very common, and depending on how you define it, it can range from 50 to all the way to 80% of kids on the spectrum. And then major depression is also starting to become an issue even for children on the spectrum. So these are the 3 most common mental health issues. And then when we look into adulthood, because we all know that we spend much more time as adults than we do as kids, and when you think about mental health, it's really a lifespan issue, I think. ADHD is a little bit less common in terms of the diagnostic features of ADHD. Anxiety is about the same, and depression really increases across the lifespan. So that's something that we see emerging for a lot of people in adolescence and into young adulthood. So these are the three things I'm going to be focusing on today.
I have a question. Is the anxiety related to aging? Have you guys looked at it at that aspect?
Yeah, there's a lot of different.
Can you repeat the question?
I'm sorry.
No, could you repeat her question?
Yes, yeah. She asked if anxiety is related to bullying,
Thank you.
and that is a risk factor for both anxiety and depression that we found for sure.
Which way are you talking? Being bullied or getting actually doing it?
Being bullied.
Being bullied,
Yeah. So from this point, this is kind of the broad scope of how common these issues are, and it's probably not a surprise to anybody who's sitting in this room. And what I want to do now is talk about these three separate conditions and maybe think a little bit about how you might recognize symptoms of them in someone with autism, and then some strategies that we know can be effective for people who have co-occurring autism and these mental health difficulties. And feel free to jump in with questions throughout. So we'll start with ADHD. The first question that we need to answer is, what is ADHD? It stands for Attention Deficit Hyperactivity Disorder. It used to be called ADD in people that didn't have a lot of hyperactivity, but now we just use a catch-all term. And one of the primary symptoms of ADHD is inattention. So things like having a really hard time paying attention to details, trouble organizing your environment and your tasks, seeming like you're not paying attention or listening to instructions, not following through on things when you need to be doing that, not having a hard time focusing on something for a long period of time. So these are what we consider the classic difficulties with attention that are common in people with ADHD, and also really common for people with both autism and ADHD. And to meet criteria for ADHD, you need to have not just fleeting symptoms of this, but it needs to really interfere with your functioning. And you need to have 6 or more of these kinds of symptoms that happen across environments. So it's not just in one setting, once a week. The other kinds of symptoms we see in ADHD are what we think of as hyperactive and impulsive kinds of symptoms. So these are things like having trouble sitting still. You've seen kids who can't sit in the classroom for more than 5 minutes at a time, so they're up and around. Or feeling restless. So some people with ADHD are able to maintain, sitting still, but they feel like they're about to crawl out of their skin because it's really hard to do that. Trouble being quiet or just being on the go are symptoms here. In terms of impulsivity, we see things like blurting out answers before the question is finished, interrupting people, having trouble waiting your turn. And again, these things, can happen across the whole population here and there. But if they're occurring at a really high level across all settings and they're interfering with your ability to do what you need to do, we would consider a diagnosis of ADHD. Does that make sense? Any questions about those symptoms?
So does this take into consideration kids with sensory processing disorder where they can't sit still or they need something to stimulate them to keep them focused, you know what I mean? Or does it take into consideration those kids that are very rigid? So they may be able to focus on preferred topics, but the non-preferred topics are completely out the window. So they're like, what do I do with my life in the 2 hours I have to sit in this class?
Yeah, so her question was, how do you differentiate sensory difficulties or very focused interest on some things but not other things? And those are really good examples of diagnostic challenges. So as a clinician, as a psychologist, when I'm doing a diagnostic assessment, part of what I'm doing is deciding if the person who has autism also has enough of these things that can't be explained by autism, then I would give them both diagnoses.
That makes sense.
Yeah. All right. So how are these two things related? Why are they so commonly co-occurring? One thing that we're learning a lot in really recent research is that there are overlapping neurobiological and genetic factors that are common to both autism and ADHD. So you may see families where there are people with just autism and people with just ADHD, but they're kind of running in the family, those two conditions. And the parts of the brain that are affected by ADHD are similar to the things that we're learning about the brain in autism. So there's some shared and overlapping factors. And then there's some things that we know are common in autism, like having a very strong focused interest on one thing, or having trouble with social attention, may look like inattention if you're just seeing a child in one setting. So there's some overlapping symptoms that are really different. The one thing that is common in both is a difficulty with executive function. And what that means is it's really a term for higher order thinking abilities or cognitive functioning. And these functions are located in the frontal part of the brain. And what they're responsible for, the reason it's called executive functioning is if you think of someone who's an executive, their job is to kind of direct and manage and keep things organized. And that's what this part of the brain is doing for people. It helps you kind of choose what's relevant in a situation and focus your attention on that relevant thing and not be distracted by all the other things that are happening in your environment. It also helps you kind of organize your own behavior so that if you have something in mind, you can keep it in mind, go about your day, and kind of make progress toward that plan. So if someone struggles with these executive functions, can you think of times where it might be hard for them for tasks? What are some thoughts that you have about that? Where would it be difficult for someone with executive function problems?
Math class.
Yeah.
Getting ready for work or school.
Yes.
Transitioning from class to class.
Transitioning, academic subjects, activities of daily living. And it's not because somebody doesn't have the cognitive ability, it's the executive functioning component sometimes that gets in the way of you being able to succeed. So these difficulties, again, are common in both ADHD without autism and autism without ADHD. And then if you have both, it's very challenging for a lot of folks. So we know also from a lot of research in both populations that people, children and adults with autism and ADHD have trouble being flexible in their thinking. So, this relates to perseverating on a particular topic. It's hard to shift your attention from that. Or if you're doing something and somebody's asking you to stop that and do something else, for people, children and adults on the spectrum, that's really hard. You sort of have to reorganize yourself. And for kids, a lot of times you'll see emotional outbursts because of that flexibility problem. Planning and organization is also a challenge because of those executive function problems. And then inhibition is a word that we use to describe being able to stop yourself from responding to distractions. So, if you think about just living in the world, what kinds of things are happening that are would be distracting if you couldn't stop yourself from responding? Like the clicking of a pen, people ruffling the papers,
Talking.
Yes, classrooms are real. There's so much happening in classrooms, or at home. There's lots of things happening that if you have trouble not responding when something's happening, it's really going to be hard for you to finish your tasks. So these are kind of core features that we think about. So if you think about the effects of these kinds of problems, you've already answered this kind of question. What are the effects? It's going to interfere with your ability to do well in school, daily activities, and it also can have a role in your social interactions, because if you're not able to pay attention or keep your attention on a conversation, that can be difficult. And then it's stressful for families sometimes if their kids are having trouble managing behaviors and completing things they need to do. So in terms of strategies, I'm a psychologist, so today I'm going to be talking about non-medical strategies for mental health issues. There are medications that can be helpful for all of these conditions, but today we're going to talk about things that don't require a prescription. So hopefully some of these strategies are things that you can implement yourselves. For young children, we know that there's strong evidence for behavioral interventions, and especially behavioral parent training. So this is kind of a model where a parent meets with a therapist and learns strategies for reinforcing positive and on-task behaviors, providing consistent consequences so that the child learns what behaviors are expected and what behaviors are not, and then lots of opportunities for practice. So typically, a behavioral parent training approach may be like a 12-week session, a series of sessions with the therapist, the parents working with the therapist in the clinic, then going home and trying things at home with their child. And this has been proven to be very effective for kids without autism with ADHD, and there's good evidence in co-occurring ADHD and ASD. So that's one strategy for young kids. In the classroom, these are things that most of you are probably going to be familiar with if you've had modifications and accommodations in the classroom. But things like having clear expectations and a reinforcement system for behaviors can really help address those executive function problems. So let's say, I have executive function problems, my brain is wired in a way that doesn't help me stay on task. Having something in the external environment to help me do that is really helpful. So positive expectations and some guidance about my behavior from someone else is helpful. You can do that with sticker charts, point systems. Sometimes a daily report card can be helpful where the teacher's tracking things during the day and sending that home. So for all of you teachers in the room, I'm sure that you are really familiar with this kind of strategy, and it can be very helpful. There's also some kind of external modifications that you can put in place in a classroom kind of situation where you might place a child in front of the class so that they're not distracted by things happening in the back of the class. Or, maybe for some kids, the back of the class is a better position for them. Essentially, you want to kind of tailor things to maximize attention and reduce distractions. Some other strategies that work pretty well is breaking things down into really small tasks and then allowing somebody to check them off as they go. Because if you have trouble keeping yourself organized, having this big amorphous thing with multiple parts is much harder than having smaller pieces of that you can work your way through. So these are helpful for elementary school all the way through college, and in the job setting you can set up accommodations like this for people that you're working with. Along the same lines, I think at home or at school, things like predictable schedules, visual schedules that use pictures can be helpful, and if somebody's able to read, having a checklist that's written is also a great accommodation and strategy that can help people stay on task. And then for adults on the spectrum, developing this for yourself and having some self-reward can work really well. And I do that for myself. If I have a task list of things to do, I'm not going to let myself watch Netflix until I've finished a certain number of those things, in an ideal world. And then, we're living in a time where technology is really helpful. So iPhones or smartphones can set reminders. You can have checklists and things like that on your phone. And kids can have that and benefit from that too, as long as it's not distracting them. So these are some ideas that you can take and use. All right, so let's move to anxiety. And just as we started with ADHD, I want to just start with some framework around what anxiety is and what we're talking about. There's a lot of different terminology that we use when we think about anxiety. One is fear, and fear is an emotional response to a threat. And that can be a real threat. We were kind of developed to have this response because it's adaptive. If there's something threatening in your environment, you want to have a physiological response to it. But over time, as social beings, now we have responses to other things. So if you have a fear of public speaking, this would be a perceived threat, even though it's not hopefully a physical threat to you. Anxiety is not exactly fear, it's more about anticipating something in the future that's going to happen. So thinking about something bad that might be coming down the pipe. That's what we think of as anxiety. And then panic is a really abrupt surge in the sensation of fear. So this can happen in a situation that you're afraid of, or it can happen out of the blue. So if anyone's ever had panic attacks, sometimes it just occurs, in the middle of your daily life or at night. So these are the three terms that we talk a lot about when we're thinking about fear and anxiety disorders. Anxiety has multiple components, and this, to me, as a psychologist, this is helpful because we can address some of these separately in our treatments. But there's a physiological component to anxiety. What things come to mind with your body when you're afraid?
Heart racing.
Yeah, heart racing, sweating.
Feel like passing out.
Yeah, feel dizzy.
Gotta go to the bathroom.
Yeah, some people have that experience, feeling like they have to go to the bathroom. You mentioned most of these. Some people feel dizzy, upset stomach, chest pain. All of these things are our body's way to kind of gear up for that fight or flight reaction. So if something threatening is in your environment, this is getting your body ready to respond to that by either, fighting back or getting out.
Could trigger a seizure as well.
Yeah. Yes, sometimes these fear responses can trigger other medical consequences if it's very intense. Okay, so that's your body's response. You also have actions or behaviors that are part of anxiety. So for children, a lot of times if they're anxious, they might just run away. Whereas an adult, if something threatening is happening, you might do that. You could also avoid things that you're afraid of, or get fidgety, start pacing, or start crying if you're upset enough. So these are sort of behavioral features that we think of with anxiety.
Anger as well.
That would be more, I think, of an emotional component. But yeah, sometimes there is that overlap when somebody's very anxious or upset that may turn into a response that looks like anger. And so the third component are thoughts. So the first is part, your body's gearing up, then you might respond behaviorally, but you're also thinking typically about what's happening. And in anxiety disorders, we see that people start to develop thoughts that are more anxious over time, and they start to fear the worst. So they might, expect really bad things to happen. They might spend a lot of time worrying about the future, or they might see things as more threatening or dangerous than they really are. So all of these things work together to sort of build over time, and can balloon out into a much bigger response over time in people with anxiety problems. So when we're thinking about intervening, we can target each of these through strategies that seem to work pretty well for anxiety. So one thing to think about is that, like I mentioned, fear is a natural, and anxiety are natural responses, and they can be helpful. Can you think of a time when it might be good to be anxious?
When you smell smoke.
Yeah, when you smell smoke, that would be a really good time to be anxious.
If you're driving at ice.
Yeah, if you're in a situation that is dangerous. What about in school?
You're confronted with a cute person you want to talk to.
Yeah, you need to be prepared
Or
for that.
don't want to talk to.
That's a good example. So when you're confronted with situations where you need to rise to the occasion, when you have a test coming up, if you're not anxious about that, you may not study for it. So it can be really helpful. So when do you think they might start to move across the line from adaptive to maladaptive?
When it starts to affect your daily life.
Yeah, exactly. When it starts to affect your life and
When they first
interfere.
start going to school.
Can you repeat that?
When they first start going to school.
Yeah, when they first start going to school and things become more stressful or you're transitioning to a new environment. Those are great examples. So if anxiety is persistent, if it's not just a fleeting thing, if it gets in the way of your functioning, and if it causes significant distress, those are signs that it's a real issue that you need to think about targeting to help the person be happier. So this is actually a focus of some of my own research, and we've done some studies to look at the most common kinds of anxiety disorders in the autism population. And the three that emerge as the most common types, there's lots of different subtypes of anxiety, but social anxiety disorder, generalized anxiety, or just worrying a lot about a lot of small things, and then specific phobias, or having a very specific fear, are the three most common, although all types of anxiety are more common in autism than in the general population. So these are the three that you're probably going to be focusing on most. So this was a study where we looked at anxiety in kids with autism over 3 different age groups, and it does look like it's increasing over time, just as depression does, and that adolescence is probably the time when we're seeing the most significant difficulties with anxiety.
Do you know for this what the difference is age-wise between school age and adolescence?
The difference between these groups, I can't remember. That's a good question. I'm thinking that it was 12 and older for adolescents, but I'd have to look back at the paper. That's a good question.
So if you extrapolated that from an adult, what do you think would happen? I haven't done the research. I've got my own observation.
Yeah, I think it continues to be significant and probably higher in the adult population, depending on, how you ask the question. So the impact of anxiety can be pretty significant. So we know that it's associated with some physical health challenges. So sleep problems, if you're very anxious, you're going to have trouble sleeping, which is then going to affect your overall health and well-being. It can lead to loneliness and isolation. So if you're feeling anxious about going out and talking to people, or if a situation is stressful and you're not going out into the community, that's going to then also have an impact on your mental health, just because of that. And then for a lot of children who are nonverbal or don't have great language abilities, sometimes anxiety is actually the root cause of challenging behaviors. So I think it's important to think about, as you're assessing the function of behaviors, to be mindful that it could be that anxiety is contributing to that. So you may want to think about strategies that help the child calm down and regulate their emotions. The other thing we know about individuals with autism is that sometimes their experience of anxiety is a little bit unique compared to the general population. So we see more common, what people may think of as unusual fears, like being afraid of beards or toilets or certain things that may have a sensory component that can trigger an anxiety response. And then just that need for sameness and predictability is also, there's an anxiety feature to that too. So I think there's a lot of overlapping symptoms when we think about autism and anxiety. But regardless of where it's coming from, I think we need to address it with our treatment. So I feel like maybe this is just my special interest, but I think anxiety has been overlooked in the autism research literature for sure, and maybe also in the treatment literature. And that could be because people on the spectrum sometimes have a hard time explaining how they're feeling. They may not have the words to do that, or they may just be unable to recognize those feelings and describe them to other people. And because anxiety is an internal experience rather than, aggression or things that we can observe, it's harder for parents and teachers and caregivers to report on that. But I think it's important because if you're not understanding the symptoms, your treatments are not potentially going to work as well. So if you're thinking about how to, monitor or recognize anxiety, asking about people's feelings is a good start, but I would try to avoid saying, how are you feeling? How does that make you feel? Like, why do you think that might be hard for someone on the spectrum?
It's an open-ended question.
Yeah.
Possibilities are endless.
Yeah, exactly. You're probably not going to help the person identify their emotions if they're having a hard time communicating that.
A lot of times kids on the spectrum don't understand the terms, if they even have them, for,
Yeah.
do I feel scared? Do I feel fear?
Yeah. I think trouble understanding the terms is a big part of it. So sometimes we can use just a very basic visual scale with pictures or words, or you can give someone options and ask them on a checklist, or do you feel this or this, and describe to them what that means. Another way to think about anxiety is just think about the behaviors that may show signs of anxiety. So facial expressions, avoiding certain situations, or getting upset in certain situations. So those are some things to monitor. And so when we think about treatments that are effective, again, I'm going to focus on non-medication treatments. The one that has the most evidence in the literature in autism is cognitive behavioral therapy. It's been most tested and studied in children and adults who have verbal ability, but there are modifications for nonverbal individuals as well. And the way CBT works, for those of you who aren't familiar with it, is that you work with a therapist one-on-one or community-based, and the therapist helps you to target those three components of anxiety: physiological reactions, actions, and thoughts. So the basic components of CBT are first psychoeducation, so learning about feelings and how to identify feelings and thoughts. understanding how they relate to each other, and then developing some skills to be able to address that. And then lots and lots of practice. So the first component, the educational component, focuses really heavily, especially for people on the spectrum, on recognizing symptoms and identifying them appropriately. Like, what does it feel like when you're afraid or anxious? What thoughts are in your head at that time? What situations tend to trigger those thoughts? So a lot of kind of talking through those kinds of things in the beginning, or with kids with little language, drawing and visual cues can be helpful. So the kind of basic idea of CBT is that thoughts influence feelings, and you can have, thoughts aren't reality, they're just how we perceive things. And so if you can change your thought and perception, you can end up changing your feeling. So let's say that we have a situation, we have a thought about that situation, and then there's a feeling. You can have different thoughts about the same situation. So let's say the situation is the kid is late for school. Their thought is, my teacher's going to be so mad at me when I get there, I'm going to be in big trouble. So what do you think that child will feel? Yeah, I'm really worried and scared. Same situation, late for school. What if the kid had the thought, my mom's driving slowly on purpose? That's going to not make them anxious, they're going to be mad. So same situation, a slightly different thought is going to lead to a really different emotion. Or they may be relieved because they don't have to do that. So I think that just is a really simple illustration of how your thoughts and perceptions of the same situation can lead to different responses. So in CBT, we work really hard on identifying those thoughts and coming up with different ways to interpret situations. And for people on the spectrum, we do a lot of work with scripted thoughts and coping thoughts that they can choose from that might be a more positive interpretation. And so that can be really helpful to have some coping skills. And then we can teach some skills around relaxation, so deep breathing. We're not going to have time to, I was hoping to have some time to do these today, but there are some strategies to teach yourself to relax your body that you can practice over time. And if you get really good at it, you can, in the moment, use these kind of skills. And then really probably the most effective component of this treatment is the exposure, the behavioral piece. So after you've worked on the skills, then you start to have the individual practice situations that might be hard for them. So you typically start with something small, practice until you feel okay with that, and move up to something more difficult. And over time, your anxiety decreases and you develop more mastery in coping skills. So here's an example of what we call these fear hierarchies, or facing your fears ladders and things like that. So this is a child who had a dog phobia, and it was so hard for him that he couldn't even read books that had dog pictures in them. So we started at a very simple, easy, which was hard for him in the beginning, of just watching movies with dogs. So he would do that, use his skills until his anxiety went down. And then once he mastered that level, we were able to move up to him going to a dog park with dogs off leash, which was like really awesome for him. So that's an example of a skill that you work over time on. Okay, so we don't have a ton of time, so I'm going to try to, I'm not going to be able to take questions, but in general for anxiety, the things that as adults or, supporters of adults with autism who have anxiety, you want to try to avoid a lot of reassurance and allowing somebody to avoid situations that are anxiety-provoking, because they're not going to learn to master those situations. Instead, you want to focus on helping them to be brave and reinforce those brave behaviors. I think it's really helpful, if anxiety is significant, to work with a therapist on this and not try it yourself. But there are some really great self-help books for anxiety, especially for adults on the spectrum, that are pretty, straightforward and easy to follow. But those are some general points. All right, so I'm going to try to get through some slides about depression, and then we'll have some time for questions at the end about any of the things we talked about. So saw in the slide earlier, depression seems to be a significant issue over time across the lifespan, especially in adolescence and adulthood. And it's been, even compared to anxiety, it's been really significantly overlooked in the autism literature. There's only recently been a focus on understanding depression, and it's a really big issue in the adult population. So we know that the rates are high, and that rates of suicidal thoughts are especially high in this population, and something that people haven't really been paying attention to at the level that they should. This was a really recent meta-analysis which looks at a bunch of studies, like all the studies that have been done on depression and autism, and they kind of gave averages across all those studies. And so it looks like in kids, around 8% of kids with autism have depression, and then it's up to about 30% in adults on the spectrum, which is way higher than the population of people without autism. So I think it's a significant issue. So symptoms of depression, I think you probably are all familiar with depression, but the two core features that we think about are depressed mood, which means basically just feeling sad, depressed, sometimes feeling hopeless and tearful for most of the day, every day, for at least 2 weeks. And then the other core feature is loss of interest. So losing interest in things that you used to enjoy or in activities. And so you would need to have one of two of these core features for an extended period of time to have a diagnosis of major depression. But you could also experience these symptoms, and it might impair your functioning, even if it's not happening as often. There's some physical symptoms of depression too, and those include changes in weight or appetite, either eating more or less than typical, changes in sleep, changes in your motor movement, so some people really slow down and other people become agitated. And then feelings of loss of energy or fatigue are kind of physical aspects of depression. And it can also have a lot of cognitive or thought-based symptoms, so feeling worthless, feeling guilt, having trouble concentrating, and then having recurrent thoughts of death or suicide. So these are the things that we think about when we're considering whether someone has depression or is depressed. In autism, as I mentioned, we don't have a ton of research on this yet, although it's emerging. We know that the challenges of transitioning to adulthood can be risk factors, major life changes or stress, and in particular, loneliness, bullying, and social isolation are risk factors specifically in this population. So I think it's something to be mindful of across childhood into adulthood, to monitor for these kinds of life challenges and changes and be sure that you're there for the person at those times. Sleep difficulties also are common in autism, and they can also be risk factors for depression. So they can kind of feed on one another. If you're depressed, you may have trouble sleeping. If you lose sleep, it's going to affect your mood even more. So it's something to be aware of. We have the same issues with recognizing depression in people with autism. So we want to probably focus on behavioral changes. So if somebody's changing their sleep habits, there's changes in energy level and things like that, or changes in interest, those would be indicators that you might want to be concerned about depression. And in the couple minutes we have left, we have some emerging evidence that the same treatments that work for people without autism are also effective for people on the spectrum. And those include cognitive therapy. Examples would be similar to what I just talked about for anxiety. And also behavioral activation. So that is helping someone to develop a scheduled, predictable group of activities during the day, because part of depression is losing interest and not wanting to engage in activities. So this therapy really focuses on making the person do it anyway, and then over time it helps your mood, even if you don't think you're going to enjoy it. All right, so that was a whirlwind of mental health and autism, but